Well, good morning, ladies and gentlemen, and thank you very much for that kind introduction. It's wonderful to be able to join you on this significant day in our calendar, European Antibiotic Awareness Day, and to discuss with you antimicrobial resistance and the interventions that are in place in the times of COVID. What's the global perspective? How have we done? How are we doing? And what light can COVID shine on AMR and our interventions? I have no conflicts of interest that would prevent me giving this talk. I think it's very much in equipoise as to whether AMR has been affected adversely or beneficially by COVID. My feeling is from the evidence that it is being adversely affected, but there are a number of issues which could cause effect either way. For example, there are a number of areas that could potentially beneficially impact AMR because of COVID. So because we've seen an increase in public health interventions such as hand hygiene, social distancing, etc., we may reduce spread and reduce antibiotic seeking behavior and therefore reduce antibiotic use and resistance as being driven. Also, because our hospitals have been so full, we've reduced our emergency surgery and other routine procedures. Sorry, fuck me, sideways! Well, thank you, ladies and gentlemen, and it's a pleasure to join you on this significant day in our calendar, European Antibiotic Awareness Day. I'd much rather prefer to be with you in Vienna in person, but it's also delightful to talk to you from Cape Town. On the issue of antimicrobial resistance and stewardship in the time of COVID, what's the global perspective and how have the two pandemics interacted? I have no conflicts of interest that would prevent me from giving this talk. The question of whether COVID has adversely or beneficially affected AMR, I think, is in equipoise. And the reason is because there are a number of different factors which may be in play. On the one hand, COVID may have reduced antimicrobial resistance or its drivers, for example, increasing hand hygiene, reducing spread of AMR in our facilities, increased social distancing in the community, and lockdowns may have reduced antibiotic seeking behavior, and a reduction in routine procedures such as surgery and others in our hospitals may reduce carriage and transmission of drug-resistant organisms. On the other hand, there are a number of factors which should increase AMR, such as an inability to isolate drug-resistant patients properly because our hospitals are full. An empirical increasing use of antibiotics, of course, would drive selection. And then there has been a concern that telemedicine distance prescribing would increase for common primary healthcare problems because of the sort of safety net approach. So it was in equipoise. I think what we've seen is that it is adversely affecting, and I'll try and show you why. So in the community and in primary healthcare, it's really viral infections that drive inappropriate antibiotic use. And the archetypal situation is, an example is in acute bronchitis, to all intents and purposes, a viral illness, but with very high levels of antibiotic prescribing seen across these different 6 countries, but you could pretty much take data from any country and show the same thing. And of course, it's therefore ironic that SARS-CoV-2 is now driving a pandemic again. A respiratory virus is causing problems. So what drove the use of increased antibiotics, or potentially could have driven the increase in antibiotic use, particularly early in the epidemic? Well, the first thing was that people were concerned that COVID-19 would be similar to influenza, great influenza pandemics of the past, in having very high bacterial co-infection. So we knew in the influenza 1918 the importance of Streptococcus pneumoniae as a co-infection, particularly in those presenting with pneumonia or pleural effusions. So was it going to be similar? We also knew from other influenza pandemics more recently, such as the 2009 H1N1, that if you were co-infected in hospital, firstly, you were more likely to remain on a ventilator or be on a ventilator, and B, you were more likely to have inpatient in-hospital mortality. And Staph aureus seemed to be the #1 bacterial pathogen in that, in the United States, particularly in that epidemic. So was COVID going to be the same? The other driver was our guidelines. Most guidelines, country guidelines, suggest for community-acquired pneumonia a regimen of a beta-lactam plus or minus a macrolide. And there was interest in macrolides for COVID because of their immunomodulatory effects, and also a now discredited paper shown in the right bottom panel, suggesting that if you added azithromycin to hydroxychloroquine, then the viral load of SARS-CoV-2 dropped more rapidly. And that led to early prescribing of azithromycin. This was despite, of course, guidelines from major organizations like WHO and then some big country guidelines such as NICE, both of which did not suggest antibiotic use for mild to moderate disease or for prevention, but did recommend for in-hospital use. However, the types of antibiotics used and for what didn't translate into the guidelines of some countries. And this study in 10 African countries from Botswana to Zimbabwe showed that watch and reserve antibiotics were being used. And I've put the reserve, the red meropenem, piptaz, and centizibactam and vancomycin as reserve, not because they're WHO EML reserve, but in the real world for low-middle countries, these are in effect reserve antibiotics of last resort. Not only that, but these antibiotics were being recommended for mild to moderate rather than severe COVID, which was incorrect. So what is really the driver of prescribing inappropriately for in the community, particularly for an undifferentiated fever or a respiratory tract infection? Well, it largely relates, I think, to diagnostic uncertainty. And there's been for a long time now an appreciation of the number of drivers of primary care over-prescribing. There are perverse incentives in some countries like China, but there's also, of course, the physician's diagnostic ability, and then the amount of diagnostic uncertainty and that tolerance of the prescriber for that diagnostic uncertainty. And the study shown on the right from China basically showed that if the prescriber was more intolerant of diagnostic ambiguity, that more antibiotic would be prescribed. But also that if the prescriber felt the patient to be intolerant, then again, more antibiotic was prescribed. So really our perception of tolerance as prescribers, not only for ourselves, but in our patients, does drive antibiotic prescribing. And while we do not have good diagnostic tests at point of care, which can tell us the difference between the bacteria and virus, unfortunately, particularly less experienced in infection management will continue to inappropriately prescribe antibiotics. So, are we missing lots of bacterial co-infections in COVID-19? Is it like influenza or is it not? Well, this living rapid review and meta-analysis updating with more recent studies, although predominantly from China, is a global look at antibiotic prescribing, need for the pool prevalence of bacterial co-infection, both in those who are so-called co-infected, in other words, presenting theoretically with a bacterial infection at the time of their presentation with COVID. And there, the global pool prevalence from this review is only just under 5%, very small. Secondary infection or co-infection, or superinfection sometimes called, is increased because those are the hospital-acquired infections, and patients' critical illness, long stay in ICUs are more likely to get true bacterial infection, and there it's about 16%. Now, the problem with this is that although the pool prevalence is very low, particularly for co-infection at entry to hospital, the proportion of patients receiving antibiotics in this review was 71%. And the majority are broad spectrum antibiotics, increasing resistance likelihood. These findings are in agreement with the findings from the very large ISARIC database, which looks at antibiotic prescribing across many different countries and different settings. And here 60%, almost 2/3 of patients admitted to hospital had an antibiotic. Now, in those that were in ICU or high care that were looked at, a subsection of these patients, 36,000 patients, 92% were receiving antibiotics. So the burden of antibiotic use is enormous in COVID. And what we also know from another review and meta-analysis by Brad Langford was that you were more likely to get an antibiotic prescribed as you moved from high-income global north countries in Europe and North America through China, the Middle East, and down into Southeast and East Asia, excluding China. And the sort of antibiotics that were being prescribed, particularly in China, were the fluoroquinolones, but then macrolides and BLICs, beta-lactam inhibitor combinations were also high on the list. Now, even if you say, okay, 5% of patients with severe pneumonia may be admitted to hospital, if you say 60% of those conservatively will receive an antibiotic, at the current time when there's been over 254 million or close to 255 million cases of COVID worldwide, that's 7.5 million antibiotic prescriptions in the last 21 months, a flooding of patients with antibiotics. And it's also important to remember it's not just co-infection with bacteria. This study highlighted that viruses and fungi could co-infect. Indeed, in patients presenting with COVID to the hospital, in this study, mainly from studies from a systematic review, mainly from studies from China and the US, viral co-infections occurred in about 10% of cases. And on entry, that was predominantly co-infection with influenza A, whereas superinfections in the hospital, predominantly rhinovirus. In fungi, co-infections at presentation were usually aspergillus, whereas in those acquired in hospital, candida, again, not particularly surprising. And in bacterial co-infection, the same sort of numbers were seen as in previous reviews. So it's not just bacteria, viruses and fungi do co-infect as well. But again, relatively low, and particularly with the viruses, unless it's influenza, it's not going to really change management. So has this massive increase in antibiotic prescribing increased resistance rates? Well, there isn't an enormous amount of data yet published on this, but the data we have suggests it is. So the Greek surveillance network of hospitals, major hospitals in Greece, has been long-standing, and it's enabled a vision of the pre-COVID pandemic levels of susceptibility or non-susceptibility and the number of isolates before and during the pandemic. And during the pandemic, months is shown in this main middle graphic in red, in blue, the non-susceptibility to various antibiotics pre-COVID. Now in Greece, in ICU setting, it was driven mainly by Acinetobacter baumannii infections and enterococcal infections. And in the Acinetobacter baumannii, they're starting at a very, very high level of resistance in Acinetobacter baumannii to the carbapenems, 90 to 100% already. But in the ICU blood cultures, they showed increasing resistance to amikacin, a drug they were having to use because of resistance to others. In the respiratory area, again, in respiratory samples, again, very high levels of non-susceptibility as a starting point, but some increase in colistin in the latter part of the second quarter of 2021. In terms of the enterococcus, there was an increasing percentage non-susceptibility both to vancomycin and to ticaplanin across these Greek hospitals of increasing concern. When it comes to Klebsiella pneumonia, there was increasing resistance seen over the pandemic period in blood cultures from the ICU to colistin, and from the wards to both second generation carbapenems, meropenem, and imipenem, and also to colistin. And then from respiratory samples, increases across carbapenems and also in quinolones. From Staph aureus point of view, MRSA increased throughout the pandemic, again suggesting increased antibiotic prescribing was a likely driver, although that's not obviously a sure thing in this study. In a different setting in New Delhi, this was a single hospital, again comparing surveillance pre-pandemic and during a 3-month period during the early pandemic, showing non-susceptibility or antimicrobial susceptibility, both gram-negative in the table above and gram-positive in the table below. And again, what it showed is a concerning increase in non-susceptibility in E. coli to cefotaxime, in Klebsiella pneumoniae to ciprofloxacin and imipenem, and in Pseudomonas to amikacin and to ceftazidime. In the gram-positives, Staph aureus increasing resistance to linezolid and cotrimoxazole, and in the Enterococcus species, also increasing resistance to with linezolid. And so, you know, a real concern there. So suggests that resistance is worsening. Sorry, I should have said that in my own, in our own backyard at Rhinosinusitis, this data courtesy of Dr. Chetner and Vani Naika from pharmacy, micro pharmacy respectively, showed that we saw a increase in non-susceptibility to macrolides in strep pneumoniae in the tracheal aspirates of patients with COVID and ICU, which was directly after a massive spike in the amount of macrolide used, predominantly in patients coming in and in the early first 24-48 hours of admission. So antimicrobial stewardship, what's happened to that in the time of COVID? Well, some countries and types of stewardship have been able to continue. So this study in primary care population-based cohort showed that during the pandemic months of January to September 2020, although there was a reduction in primary care consultations for respiratory tract infections, the actual proportion getting an antibiotic stayed pretty much the same. So they were unable to continue their stewardship efforts. Urinary tract infections also, their consultations also reduced. Overall, a little less dramatically than for respiratory tract, but again, the proportion receiving the antibiotic didn't really change. So this was able to maintain stewardship. In contrast, a survey study of pharmacists across the UK in hospitals who run many of the antimicrobial stewardship programs demonstrated that there was significant negative impact of COVID on the antimicrobial stewardship activities. And in the figure, the graph on your right, this is everything in red is a negative impact. So daily stewardship rounds and multidisciplinary meetings, their ability to have time to update their guidelines, audits, etc., were all adversely impacted. The only thing to really come out positively was the feeling that they were able to use technology to facilitate stewardship, virtual meetings and rounds. And interestingly, that seemed to reduce the separation of pharmacists from the prescribers and other members of the team, and it increased collegiality of the multidisciplinary collaboration, which is an interesting finding. There was also this concern, as I mentioned earlier, that antibiotic prescribing may increase in distance consultations and virtual consultations because of the safety net. This is just one study in patients presenting with acute rhinosinusitis, published in the Laryngology journal, which actually showed the opposite, that during the pandemic months, your odds ratio of receiving the antibiotic was reduced, and indeed the type of antibiotic didn't change. So it didn't have the feared consequence or distance stewardship of increasing antibiotic resistance. There are some specific set piece issues in stewardship which have been important to recognize during the COVID pandemic, particularly in relation to fungi. So mucormycosis epidemic in India was brought about by this unhappy meeting, the triad of COVID-19 with a very high number of diabetics and then getting high dose corticosteroids, both of which drive mucormycosis presentations and really very, very severe illness. And then in countries with high HIV co-infection, the concern of differentiating presentation of severe COVID with Pneumocystis pneumoniae, and generally, particularly for patients with low CD4 counts in HIV, we would treat for both. Biomarkers, unfortunately, are not the answer to all woes, particularly in COVID. CRP and procalcitonin are poor discriminators of COVID versus other infection. And the procalcitonin is a marker of severity of COVID, largely driven by the cytokine storm, and cannot be used really to differentiate. There have been publications suggesting you can use PCT-guided antibiotic therapy, but actually the bias in these is very high. They're very heterologous studies, and they're mainly observational. So in the final part of the talk, I want to move to how COVID-19, our response to COVID-19 has shone a light on AMR, not only in showing us perhaps where we have challenges, but where potential possibilities lie to improve our interventions. The first thing, which I think has become evidently clear, is the parallel between the destruction of environments and therefore increasing zoonotic infections, for example, infections from bats. As you destroy their environments, bringing them closer to human habitation, has driven COVID. So too is antimicrobial resistance, particularly antibacterial resistance, driven by our destruction of our own environment, our inability to live in symbiosis with our gut microbiota, which have critical functions both with our immunity, digestion and well-being, and are now implicated in multiple different associations with disease and health. We also have framed antibiotic resistance and antimicrobial resistance in completely the wrong way. In so doing, in this environmental destruction of our own symbiotic relationships in our bodies, creating war and waging war against these bacteria is exactly the opposite of what we need to do. There needs to be a reset, make peace, not war, with bacteria. COVID-19 has highlighted how important and how effective rapid diagnostics are, not only to direct treatment, but to be able to isolate and reduce transmission. Whereas we've now got, very rapidly, we've had rapid diagnostic tests and PCRs, and even whole genome sequencing, this really is falling behind in AMR, antibiotic resistance in particular. And particularly whole genome sequencing really gives opportunities for the future. The sewage whole genome sequencing studies looking at antimicrobial resistance in sewage is giving some very, very interesting pointers into what's driving antibiotic resistance in low middle income countries, which seems to be infection prevention lack rather than antibiotic use. So watch this space, but we need to use these technologies. COVID has also shown us, again, our reliance on old medicines. For COVID, it's oxygen and steroids. And for antibiotic bacterial infections, it is, of course, workhorse antibiotics, narrow spectrum penicillins and the like. And it's still true that more children under 5 die of infection, bacterial infection, because of lack of access to antibiotic than to antibiotic resistance. And while this continues, it is totally unacceptable. But COVID has shown us how much we rely on old medicines. And so we need to redouble our efforts to make countries, funding bodies aware of the fact that there are shortages of old workhorse antimicrobials that need to be produced. COVID has also shown us what we can do when we are set to a single purpose. So this was the sort of contribution in our hospital to our COVID team, everybody working towards a common goal. We're still not united in the fight, well, not the fight, apologies, in the mitigation of antibiotic-resistant antimicrobial resistance. Antimicrobial resistance or antibiotic stewardship, antimicrobial stewardship, sits hand in hand with infection control, and particularly in hospitals with infection prevention control, such as hand hygiene. I would say that in COVID, the increased compliance with such measures has been driven by fear for the self. In other words, the healthcare workers' fear of their own infection rather than altruistic hope to prevent infection in our patients. Sadly, once COVID threat has reduced, that hand hygiene and whole infection prevention control focus is lost. And we need to understand what these drivers are and how we could not threaten people and cause threat and feel harm, but what is it that helps drive, and is there anything in there we can use? In terms of threat, we've also seen how important real-time surveillance is in COVID-19. And we've seen from these dashboards and these apps how potent watching cases increase and deaths increase can drive our use of public health interventions and our advocacy for change. Unfortunately, this is in contrast to what we've been doing in antimicrobial resistance, in which we've been trying to articulate threat from modeling of futuristic projections. And that leaves people disconnected and disinterested. You need real-time surveillance. There's no reason why we can't do the same in COVID as we've done in as we do in AMR, as we've done in COVID. This example from my own region, I'm in the Western Cape. The Western Cape Department of Health Data Health Information Centre now has a dashboard for drug-resistant TB cases, showing us the number of positive cases, the percentage resistance, and where they're happening. Again, an ability for immediate change in focus and potential areas of hotspots to be identified. But ultimately, we still are faced with this conundrum and greatest challenge that people don't, outside of the field, do not recognize what AMR is, partly because our language is so poor and we don't get to focus on the point of it. People don't understand the terminology, but more importantly, because it's such a diffuse issue, including bacteria, from many different bacteria, many different resistance profiles, and many different infections. Ask a person to shut their eyes and conjure up an image of COVID or Ebola would be simple, and they would feel that. Ask them to do so for antimicrobial resistance, and they're likely to look blank. And this is our challenge. How do we change this? We need to create a civil society of people who have been infected with drug-resistant organisms. We need to give them the opportunity to tell their stories to a greater extent than we're already doing. And we need to create a critical mass of people with an interest in this who can try and drive change. Lastly, the issue of access. COVID-19 has really brought into the spotlight the question of access, and particularly the inequity of access, particularly in this case to vaccines, but not just to vaccines, to therapeutics and diagnostics as well. The ACT accelerator, which is meant to donate vaccines, diagnostics and therapeutics to low and middle income countries, is aspirational and a dream, but the amount of investment that's yet to take place is minimal compared to the aspiration. And while high income countries continue to hoard vaccines at the expense of low income countries and their populations, this chasm continues. And the chasm divide in antimicrobial resistance is also there. There is a divide between the needs of the global north and the needs of the global south. The global north is industrialized, has spent decades improving the social determinants, reducing the social determinants of infectious diseases, clean water, safe sanitation, vaccination programs, and general increase in health. Whereas low middle income countries have not made that step. And therefore the burden of infection is so high that that is what is driving antibiotic prescribing. So the benefit to the global south of a new antibiotic or two new antibiotics is not going to shift the compass, shift the needle. Whereas it is in the high income countries, what shifts the needle in low middle income countries in the global south is improving infection prevention, reducing burden of disease. Now, this looks to be insoluble at the moment, but this quote from John W. Gardner in 1965 always comes to mind, because insoluble problems are actually breathtaking opportunities. And if we can really link our interventions in AMR to what is needed in different areas of the world and stop all the money going into research and development for new antimicrobials and on surveillance, which favors the high-income countries of the global north to a much greater extent than the global south, and puts a bit more money into our problems, then I think equity will be improved. So to conclude my talk, I've shown you that what I think is diagnostic uncertainty and the concerns about the mimicking of COVID-19 and influenza in bacterial co-infections may have driven the early pressure of antibiotic prescribing. However, with the data that we now have, there should be no excuse for this really anymore. The data is starting to show that because of this increased antibiotic prescribing, we are getting increased antibiotic resistance in our bacteria. Stewardship programs have been detrimentally affected. Technology does offer some hope in new directions. I think we need to think long and hard about how we can use that to improve the way we optimize antibiotic use, both in humans and of course in animal health too, potentially. I think that COVID has shone a very harsh light on our attempts to mitigate antimicrobial resistance. And it really has exposed this divide between the haves of the global north and the haves not of the global south. And in so doing, we need a rethink on the interventions we're using to mitigate and where money should flow into our mitigation attempts. So with that, I send you all greetings from beautiful Cape Town, the mother city. This is Table Mountain in the distance. And these are the winelands of the Constantia Valley and the Constantia Vineyards. And I hope that the rest of your conference today is very successful and fruitful. And from everybody, on behalf of everybody in South Africa, feeling for you and thinking of you in this time of increasing COVID pressure in Austria. Thank you very much.